Good afternoon. I'm Dr. Joss Reimer, the medical lead for the Vaccine Implementation Task Force. We have reached some incredible milestones this week in our vaccine rollout. Collectively, over 1.5 million doses have been administered in this incredible achievement. But each and every one of those doses came from a decision that someone in Manitoba made. You decided to roll up your sleeve, to book an appointment for your parent, for your child, to get yourself to an appointment, to go to a walk-in, to get that earlier vaccine. You made these decisions, and for some of you that was easy, and we know there were people who booked as soon as they were eligible, but some of you did it because you want to get to the other side of this pandemic, and you know the vaccine's the way to get there. We also know that many of you had questions, and perhaps had those answered before getting the shot, maybe from your healthcare provider, from a reliable source of vaccine information, maybe even from listening to us here every week. But today I want to talk to some of the people who still have questions, who may not be sure, and may not be confident in the decision to get the vaccine. Nous sommes aussi conscients que beaucoup d'entre vous avaient des questions. Peut-être avez-vous eu des réponses avant de vous faire vacciner, par exemple auprès de votre professionnel de la santé, d'une source d'information fiable sur les vaccins, ou même en nous écoutant ici chaque semaine. Aujourd'hui, je veux m'adresser à ceux qui ont encore des questions ou des hésitations au sujet du vaccin. There are two top reasons that we hear most often, and they're somewhat interconnected. So concerns about how quickly the vaccine was developed, and concerns about how quickly it was approved for use. The suspicion and the fear that underlines both of these is that the speed in which this happened means that perhaps steps were skipped, and that somehow the vaccine must not be safe or it's untested. So today I want to break that down a little bit. So first, I want to talk about how quickly the vaccines were developed. It is easy to see why people wonder about this, because in other situations, these developments can and do take years. In fact, when work began on the COVID vaccine last year, I don't really think that many of us expected we would be in the position we are today, with vaccines approved for use, and with supplies at a level that we could immunize a substantial portion of our population. Fortunately, scientists and other experts around the world were not starting from scratch. While this coronavirus is new, it is not the only coronavirus that we have dealt with. There are hundreds of different variations of coronavirus. We have studied them. We have responded to serious worldwide health emergencies linked to them, like the SARS pandemic, for example. So in this case, it only took 2 weeks from when COVID-19 was first detected to map the entire genome of the virus. And that told us what kind of vaccine we would need in order to stop the virus. As a comparison, it took us 13 years to map the human genome, which was a major scientific achievement in 2003. But since then, the science on DNA mapping has developed immensely, and that allowed such a fast mapping of the coronavirus genome during this pandemic, because we now are able to do this at a quick speed even outside of pandemics. The scale of international partnership and collaboration that was needed to develop a vaccine was unprecedented. There were and are numerous vaccines in development, all at the same time, being led by different companies in different countries using different types of vaccines. That in and of itself is unique and gives the world a much larger pool of vaccine candidates. And a larger pool means the odds were better that some of them would prove to be effective, and others would prove not to be effective and have to be put to the side. Normally, this large number of projects would not be financially possible because there's a lot of financial risk that companies need to take in order to develop a vaccine. If it ends up that their vaccine doesn't work, the companies can lose a lot of money. With COVID-19, governments and some private businesses took on the financial risk instead of expecting the vaccine companies to do it all themselves. So that meant that the companies knew that even if their vaccines didn't work and needed to be thrown away, that they still would be compensated for their work. So this allowed the companies to do work faster because they had that financial security, and to try new ideas that normally may have been too financially risky because if they didn't work, they would lose money. Those companies took different approaches to developing how the vaccine would work and how it would get the message to your immune system to identify and fight off COVID-19. But again, in this case, the groundwork was already laid. Viral vector vaccines, like AstraZeneca, have been used for decades in Canada and around the world. This technology is used in some of the vaccines that you may be more familiar with. mRNA vaccines, like Pfizer and Moderna, are a newer technology, but I want to be clear that that doesn't mean that they haven't been tested or studied. In fact, human trials of cancer vaccines using the same mRNA technology have been taking place since 2011. And work is also underway on a new rabies vaccine using this technology. Moderna, for example, already had an influenza mRNA vaccine developed before the pandemic started. So we were able to take something that was already in development and adapt it to the COVID pandemic. The simplest comparison might be that while the message we needed to send to our immune system was different, we already knew which envelopes to use. Nous avons pris une technologie qui était déjà en développement et nous l'avons adaptée aux besoins de la pandémie. La comparaison le plus simple que nous pourrions faire, c'est celle d'un message que nous voudrions envoyer à notre système immunitaire, même s'il s'agissait d'un message différent. Nous savions déjà quelle enveloppe utiliser pour l'envoyer. In other circumstances, this process of developing a vaccine can take years, and so that brings us back to the question about how these vaccines were developed so fast and whether or not any steps were skipped. The steps that are truly important and the ones we care the most about are the underlying science, the medical evaluation, the clinical trials where the vaccines were tested on animals and on people who agreed to participate. Those all happened as they needed to, as they would for any other vaccine. What changed was the pace. Clinical trials on thousands of people happened at the same time with different vaccines all around the world. The same kinds of data about safety and effectiveness were gathered and analyzed. What really changed was the pace of many of the processes that support the science. Weeks, months, sometimes even years can be spent advocating for a new intervention. Can be spent compiling foundational research, seeking out funding, recruiting people for clinical trials, getting the right approvals in place, and dealing with all the administration that goes along with the science. All of that was incredibly condensed in this case. For example, it was very easy for the studies to recruit participants. Volunteers were very eager to take part all around the world. It was also much easier to study how well the vaccine protected against the virus because there was so much virus present around the world. Normally, you have to wait quite a while before a large number of your participants are exposed to a virus that you're studying. You know, for example, there's just not that much mumps virus circulating in the world at any given time. And so we have to wait for people to be exposed before we can see whether or not the vaccine works to protect them. This time, the exposures were happening to participants regularly, and so it did not take very long to get that information. So that addresses in a very brief way how the vaccines themselves were developed so quickly. Some made it through that process, many others did not. So that gets us to the next step, the next question that people have asked me many times. is how and why were the vaccines approved for use so quickly? So the federal government, specifically Health Canada, is responsible for reviewing and authorizing vaccines, prescription drugs, and other medical interventions for use. Again, for COVID-19, the same processes were followed as for any other vaccine. All prescription medications and vaccines are required to complete 3 trial phases before approval. A phase 1 trial uses a small number of participants to look at safety. So these trials will test various doses of the product to see what side effects occur and how tolerable they are for participants. Phase 2 trials are a bit larger and typically include a larger variety of participants as well. Phase 2 vaccine trials look at the immune response and ensure that the vaccine triggers the immune response the way that it should. And then finally, phase 3 trials are much larger, with thousands of participants. This is the trial that starts to look at how well the vaccine actually prevents infection. And these are the trials that you've heard about in the media. These are the trials where the mRNA vaccines showed that they prevented infection about 95% of the time. So the science didn't change, but again, the timelines for all of the administrative processes that support the science were condensed. So normally Health Canada requires companies to submit their data from phase 1, 2, and 3 at the same time for evaluation. In this case, Health Canada reviewed each phase of the trial as it was completed. So while the same review occurred, it meant that less time was required at the end of the phase 3 trial in order to get approval because phase 1 and 2 had already been reviewed. They were able to do this because Health Canada prioritized these approvals over anything else in the queue. So the companies did not need to wait their turn to have their application reviewed. They were done in real time. I also want to be clear that the evaluation of these vaccines does not stop once they're approved for use, and that is true for all vaccines that we use. Canada has one of the best vaccine monitoring systems in the world. And we use the information that we gather and the information from countries all over the world to guide our decisions. So we've seen that happen when it came to the use of AstraZeneca and the very rare but serious side effects of blood clots with low platelets. We've seen it as well in the even rarer reports of myocarditis first observed in the US and Israel, just to provide a few examples. So I know it can be a challenge to wade through all of the information out there about vaccines, especially when you have questions. But I do want to correct the information and make sure people know that these vaccines were tested, they were approved, and they were shown to be safe and effective in the same way as other vaccines. The science behind these vaccines is solid. It's built on technology that we know and that we understand. Ce vaccin repose sur une science solide. Ils sont sécuritaires, ils sont efficaces et ils reposent sur une technologie que nous connaissons et que nous comprenons. And maybe when we look back at this pandemic at some point in the future, now that we've seen how the world can come together to solve a health crisis, the real question may be why other vaccines and other medical interventions take so long. Vaccine development has not been the only area of our work where we have learned, where we have developed and adapted in order to end the pandemic. We heard this week from Dr. Anderson that COVID-19 affects different people in Manitoba differently. In the first 2 waves of the pandemic, elderly Manitobans were facing the most severe impacts of the virus. We saw tragic loss occurring throughout our personal care homes. And Manitobans were rightly concerned about protecting our seniors, first and foremost. So in keeping with NACI advice, we prioritized seniors in our vaccine rollout to ensure the most vulnerable Manitobans were protected with the vaccines based on the science and epidemiology that we had at the time. In partnership with the First Nations Pandemic Response Team and following the leadership of our First Nations health experts, the analysis and data gathering that was done to understand the impacts of COVID on First Nations people also helped us see the clear indication that First Nations people were susceptible to the virus and severe outcomes at younger ages. So we created an age differential for First Nations people that would continue to focus on the most vulnerable, including First Nations seniors who were more vulnerable at younger ages. And through the leadership of Dr. Anderson, of our surveillance team, of the stakeholders who worked with her on the race, ethnicity, and indigeneity data, and in part because we were so successful in vaccinating seniors, we saw trends in the second wave and heading into the third wave that Black people, Indigenous people, and people of color became even more prevalent in our case data. The report released in March was instrumental in allowing the task force to get approval for the priority community approach that occurred in April. The original report, as well as ongoing REI analyses, allowed us to prioritize certain communities in an evidence-based fashion, just as the previous decisions on the age-based approach were evidence-based. So as a result of the great work that this team did, we were able to quickly implement the priority community approach, where neighborhoods across the province that were at highest risk of the virus due to race, income, and other social determinants of health were prioritized for vaccine eligibility. The REI work has also informed the expansion to more localized delivery models and the investment in the community grant program, which has helped to work towards reducing systemic barriers that existed prior to the pandemic and will continue to affect BIPOC communities. And hopefully these grants will help us to overcome some of these barriers through intensive local and community-based activities. To my knowledge, we're the only jurisdiction in Canada to have produced this type of data, and so my sincere thanks goes out to the whole team that made it happen. Whether it's been about vaccine development, vaccine delivery, Dr. Roussen's work with the public health orders, we've been working together, learning together, and adapting to new information as we receive it. So we have, and we continue to want to understand what's happening on the ground. We're committed to data and science in our work, and we're committed to adapting to what we learn each day about the pandemic and how to end it. So I'm really proud of the Manitobans who have trusted us, who've been keen to learn from us and learn from us about the data and the science, and those who have turned out in record numbers to be vaccinated. The next few months will be critical as we develop the final thousands of doses, as we deliver the final thousands of doses to 10, 50, 100 Manitobans at a time. And because of our ability to adapt to what the science and data is teaching us, we're able to arrive at where we are today and continue to improve our rollout. That same commitment is what will get us across the finish line of this effort. And so with that, I will turn it over to Johanu.
Thank you very much, Dr. Reimer. Good afternoon, everyone. I'm Johanu Botha, the Operations, Logistics and Planning Lead for the Vaccine Implementation Task Force. This week, Manitobans have achieved several significant milestones in the vaccine rollout. More than 1.5 million doses have now been given. More than 75% of people have at least had one dose, and more than half of Manitobans have had 2 doses, making us amongst the most vaccinated people in the country. Every day, thousands of people are getting their shot. We're doing our part to make it easier with walk-in appointments at super sites, extended hours, and community partnerships that make being immunized even more convenient. Because we know that we have more to accomplish, and we'll do that with your help. Earlier today, the Premier announced the next big event to help us reach our next milestone. So next Wednesday, July 14th, every super site in this province is going to provide all walk-ins all day. We've got 20,000 doses waiting for you. This has the potential to jump us further ahead on our targets, all in one day. So whether you need your first or your second dose, bring yourself, have a family member tag along, or tell a friend to meet you in line. Come join us next Wednesday. There will be Moderna and Pfizer at every super site. That means RBC and Leela in Winnipeg, Brandon, Selkirk, Dauphin and Steinbach, Thompson, Gimli, The Pas, and Morden. The 8,000 Pfizer doses spread out across the province will be prioritized for young people aged 12 to 17 because we know that there is still a need there that outstrips the current supply of Pfizer. You can find the hours of each super site on our website, protectmb.ca, and using the interactive map. Our next vaccine milestones are within reach, but we can't do it without you. That's because we've also reached a new place in our vaccine rollout that we've never been at before. I think it's fair to say that for the first time, we are likely going to see that our vaccine supply is going to consistently be more than the daily demand. We've come a long way since we were counting doses arriving or administered in the hundreds. But over the next few weeks, we've been allocated by the federal government more than 405,000 doses, including almost 300,000 Pfizer and more than 100,000 Moderna. We have our vaccine distribution systems in place and ready to administer these, whether that's our walk-in day, booked appointments at our super sites and pop-ups, community clinics, of course, medical clinics and pharmacies across the province, urban indigenous clinics. But we can only get vaccines in arms when there are arms at these sites. As of this week, we had more than 180,000 vaccine appointments booked in the weeks ahead. And the reality is that if you want the dose and don't have an appointment yet, we have one for you. We have one for you now. Make an appointment or stop by as a walk-in at one of our sites. Our progress as a province from here on out will largely depend on Manitobans' willingness to get the earliest dose available to them, whether and however it's most convenient, and whether it's the first or the second dose. We've talked a lot about velocity and about speed. We are moving into a place where that velocity, that speed, the amount of doses that we administer each day depends on the demand out there, on individuals showing up. I'm really proud of our team and the work we've done to build this vaccine system. If you haven't yet, now is the time to come check it out for yourself. I do want to share one of the community outreach initiatives that was really successful in the Northern Regional Health Authority. In June, Public Health held an outreach clinic at a housing property in the Pas. It was in a lower income neighborhood where there had been some COVID cases, so people had been or were self-isolating and might not have had the opportunity to be immunized. The region brought several public health nurses and a nursing student to give the vaccine, and they also provided COVID tests if that was appropriate, and they provided other public health support to community members as well. The team set up in a central location, but then also went door to door to connect with people who could not come to them. They provided snacks and helped to support this community by reaching people who might not otherwise have been immunized. That day, the team provided the vaccine to 19 adults. For 17 of them, it was their first dose. They also immunized 5 young people. Now, we've talked a lot about the thousands of doses we can administer every day, but sometimes it can be the dozen doses provided to people who might not otherwise be immunized that will be a real change maker in the community. Thanks to everyone in the region and in the Pas who helped to make this day a success. Before we wrap up, I also wanted to provide a quick update on immunization cards and immunization records. One of the challenges that needed to be addressed was how people without internet access could either update or correct their immunization card or request their immunization card. Effective today, people who need to or would prefer to do this by phone, as opposed to the online option, can contact our vaccine call center, the usual number, 1-844-626-8222, and follow the prompts for either their immunization record information correction or to apply for the immunization card. Thanks to everyone for their patience as we work to put this solution in place. And with that, we can go to questions.
Thank you. A reminder to our reporters on the line, you will have one preliminary and two follow-up questions. Up first this afternoon from the Winnipeg Sun, Scott.
Hi, good afternoon to both of you. I guess first question for Dr. Reimer. Going back to the BIPOC community, I guess I'm trying to understand why would other minorities outside of First Nations be overlooked when some, and maybe perhaps most, of the same barriers can be applied, to those, different races and ethnicities as well. It seemed that from Dr. Anderson that it almost there was an oversight here by the vaccine team.
So we saw in the data that we had very early on in the vaccine rollout that there was a clear overrepresentation of First Nations people in hospitalization, in ICU admissions. We regularly saw over half of our hospitalized COVID patients being First Nations people, which means that it was a massive increased risk for that group, as well as a major source of resources being required from the healthcare system. So based on that data, very early on, thanks to the great work of the First Nations health leaders, we adjusted our approach to try to get vaccines to First Nations people as quickly as possible through multiple mechanisms. So the age discrepancy being one mechanism, but also working to have vaccines go to all of the First Nations communities throughout Manitoba in January as well. The data we had at the time also very clearly demonstrated that the age-based approach was the best way to reach the highest risk folks the fastest. And at that time, where we had so little supply, we had to really focus in on only the highest risk groups, which meant difficult decisions every day when we were expanding priority groups and expanding access. And so as we were getting more supply and new data was being developed, like the REI report that came out in March, we were able to continually improve eligibility and expand eligibility to other groups that maybe weren't the absolute highest risk, but still very clearly experienced more negative outcomes compared to other people. So that work continued throughout until we were able to make everybody eligible. It also included, expansions when we saw that pregnancy was a high risk area. And when we saw certain health conditions were higher risk for severe outcomes. So that was extremely challenging work to do at that time as data was coming in regularly. But I think we did the best that we could with the information that we had to reach the highest risk Manitobans as quickly as possible.
All right, thanks for that. One of the things that was brought up, and not from you guys, from what we've heard during this, was, but stigma attached to it, and how it got in the way of vaccinating people, especially in BIPOC communities. How much have you seen at this point that affected those communities in terms of some of the messaging that did come out from government, not necessarily the vaccine team, but government itself?
I think we see that stigma is always a challenge and can have negative impacts, not just in vaccine, but in many different health conditions and scenarios. And so, certainly the message that we are trying to give to Manitobans is that we want everybody to be vaccinated, and we want to make it as easy as possible for people to be vaccinated, because we recognize that people have different situations. They experience different barriers. They experience different pressures. And so, it's our job to try to provide a fast, an efficient rollout, but also to tailor that so that we do help people who experience those barriers to get access as well. And we certainly don't want anyone to be stigmatized for things that are out of their control. We really value how hard Manitobans have worked to get their vaccines, and we're going to keep working as hard as we can to reduce those barriers through community clinics, through the walk-in day, as well as other walk-ins, through the grant process, through our physician and pharmacy partners. And I hope that all of them are providing the same message that everybody is welcome whenever you come.
Thank you for that. Final question for Johanu. Where are we at with the 3%, so to speak, that have had issues with getting, I guess, their vaccine records to get their cards? And I guess on top of that, what is the average wait time to get that physical card right now? Because it seems like for many it's well over 2 weeks.
So in terms of having the record corrected, it's less than 1% now of data that's entered every single day that requires some kind of correction or where we get some kind of query. And so with over 1.5 million doses entered into the system one way or another, and for at least over the last couple of weeks, over 20,000 doses a day, that under 1%, well, ideally it's 0, it's an improvement. In terms of the timeline to having the record corrected, it really depends on where the individual had their dose administered. In some cases, it can take longer if it was at a community-hosted clinic or at a pharmacy or a physician. If it was out of province, that we have to work through some of those things. So it really does vary. But for the most part, we are able to address the record correction piece within a week. In terms of the timeline to receiving the vaccination card in the mail, if that was the question, Scott, I'm not sure on the average there. So that might be a question for us to follow up on. By all accounts, people are receiving their cards in an okay fashion, but I don't have an average timeline on making the order and then receiving it in the mail at this time.
Great, thank you.
From CBC Radio Canada, Mohammed.
Hello to both of you, Mohammed with Radio Canada. My first question, would you be able to share any numbers or indicators to show the effect of incentive on the vaccination campaign since the beginning of that in June?
I'll go first, then I go to Dr. Reimer. I think whenever we get questions on the impact of any particular strategy or approach to enhance coverage, we look at everything that we're doing, and our answer is that it's very tough to pinpoint one particular solution to increasing coverage in terms of that dose 1 coverage specifically, so sort of inching up beyond that 75%. I think there's a number of things at play there, the community-hosted clinics that focus on dose 1 individuals, the incentives that are there. We did notice a leveling off at that dose 1 coverage, and then as incentives came up and the community-hosted clinics came up, there was sort of inching back up. So it has some impact. I think it's tough to distill precisely which solution adds to which jump up on the coverage. So we just use all the tools in the toolkit. I don't know, Dr. Reimer, if there's anything else.
I mean, even for one individual, it's rarely one factor that leads them to make a decision to be immunized or not immunized. So, for some people, it was strictly wanting to protect their own health. For other people, it was wanting to protect the health of a loved one who was more vulnerable. And for some people, it might have been something like a lottery that put them over that decision point. But none of the incentives would be enough to have somebody make a decision based on that alone. If somebody didn't want the vaccine, we don't expect that something like a lottery would take someone who's against getting the vaccine and shift them to receive it. All of these are complex decisions that people make. And so we want to try to promote vaccines in every way that we can, so that for each individual there are many reasons that they see the vaccine as beneficial to them, to their loved ones, and to their communities. And neither at the individual nor at the community level do I expect that we'll ever be able to clearly outline which incentives were more effective than others.
Great. Thank you very much. My follow-up is about the immunization card. To get this card, you have to provide your health card ID numbers, but some people, like foreign students or recent newcomers, are not eligible for or health cards. Do you plan to make changes to the information needed to get an immunization card in the future?
So the use of the card and who receives a card and the benefits of the card or what comes with it is more of I think a government policy decision. At the moment, it's tied to having a health card. I think there's work in place to, as much as feasible, provide a unique identifier for someone who doesn't have a Manitoba health card, but essentially is a Manitoba resident for a period of time, so they can have this card. There is, I believe, there's work like that in place. But the use of the card and what comes with it is a question that transcends the sort of the operational logistical side of getting doses in arms. That's the focus of the task force. Yeah.
Thank you. And I think my next question is for Dr. Reimer. I think you already tackled this issue, but can you explain to us why mixing vaccines safe? Was it something that we've seen before the pandemic?
Sorry, that was mixing vaccines?
Yes.
So mixing brand types is something that we do regularly outside of the pandemic. People don't typically know what brand of vaccine they're getting, and this is the first time that the public has ever paid attention to the individual brands as a whole. And there's been a lot of focus on that worldwide. But outside of COVID, we use various brands either from year to year, or even sometimes within the same series of vaccines for many different vaccine types. So influenza, hepatitis, the rotavirus, there's many examples where we do mix brands, and sometimes we even mix the type of vaccine for people. And so this is not new to us at all. We started with a very cautious approach because this was such a big scale that we wanted to do what we had the most evidence for, and that was to follow the original trials from the manufacturers. But as more and more information came worldwide and billions of doses have been administered, we saw that this vaccine creates an immune response the same way as other vaccines and behaves in the same way as other vaccines, and that helped us feel confident that we could mix vaccines the same way we do with other viruses.
Thank you.
From CBC Manitoba, Bart.
Hi there. Mr. Botha, the vaccine tax briefing posted this morning shows second doses likely exceeding the August 2nd target sometime in the middle of August. And my colleague Caitlin Gowerlich noticed on that slide that instead of being on track subject to supply, you've changed it to subject to demand. Do you think that mid-August forecast is likely based on what you see with demand trends?
So that was a good catch, and certainly that is a sort of a change in how we're viewing the rollout, and sort of why I stressed it earlier during the speaking notes. We have moved into a space where we've built all this capacity, tons of capacity throughout the province, and we have the supply now that can move through it. So the main indicator of how many doses we're able to do each day and how fast we get to the target or beat our target is going to be on the demand side, meaning how fast and how many Manitobans go get their first and their second doses. In terms of how confident we are on that projection on the graph that was in the tech briefing, I think we are confident in saying that we are on track to beat our targets. I think we're very hesitant to lock us into a specific day because from here on out, a large amount of this is out of our control. It is really about how many Manitobans show up and how quickly they show up to pump up those dose 1 and dose 2 targets. So confident that we'll get to our target in time at this time, given what we're seeing in booking behavior and so on, but hesitant to lock us into a day.
What would you suggest would be the maximum reasonable, foreseeable, realistic first dose level in Manitoba in terms of percentage of eligible Manitobans?
Well, like I said, I think that we are currently confident that we can meet that 80% first dose target on time, and then we'll take it from there after that.
Okay. Dr. Reimer, what's the latest intel with, schools coming back in September, probably full capacity everywhere. So what's the latest intel on Moderna approval federally for youth 12 to 17 or Pfizer approval for children 5 to 11?
Yeah, so Health Canada has adjusted their broad estimates for timeline for a decision on Moderna approval for 12 to 17. They had originally been thinking it would be end of June. They're now talking mid-July for a decision. Of course, they haven't given us an exact date, and so we'll have to wait and see what they end up deciding. But it does sound like mid-July is their estimate for now. Both Moderna and Pfizer are working on trials for age 6 months up to 11 years. And we are expecting that the first results, which will probably be for those age 5 to 11, might come out in September and seek approval from Health Canada after that. But there's still many different factors that could adjust those timelines. So that's sort of our planning assumption on our side right now, is that it's possible that we could see some approvals down to age 5 in September, but that's very much out of our control and even out of Health Canada's control, as the companies are still working on those trials as we speak. So we have no results on them yet.
Thanks.
From the Canadian Press, Steve.
Oh, hi there. Last time we spoke, you had mentioned, Mr. Botha, that you were seeing an uptick, a slight uptick from that plateau in first dose vaccinations. It was around the 0.2 to 0.3% per day in terms of the percentage points increasing. Is that ongoing? What have we seen in terms of the uptake, the ongoing uptake in first doses?
I feel like it's been fairly steady on that front. There was a bit of a slowdown over the weekend, and I'm not sure if it was just the weekend or it's because during the week the community-hosted clinics that are geared towards dose 1 coverage, there's just more of them scheduled. So I don't know if that impacted the weekend, because we saw on Monday we're sort of back at that 0.3. It was 1.4 day. So I think it's still a watch and see. We're steadily inching up on the dose 1 coverage at a rate, as I was saying to Bart, that still makes us feel comfortable at the moment to say that we'll meet the target for 80%. And I think what will be really telling is over the next couple of weeks, when we've got more community-hosted clinics running, really geared towards areas that are facing barriers to receiving a first dose. As those continue on, we'll probably keep chugging away at that figure, but it's slower work. I think we're seeing this across the country, where after 75% or so, it's slower work. So slower, but no indication that it's slowing down entirely.
And what are I know the outreach programs to certain communities were announced earlier, but are they just getting underway now, or can you give us an idea as to sort of the pace of the rollout and where we stand?
So there was the initial 20,000 doses or so that was allocated to them. They started last week. I don't actually offhand have on hand how many of that 20,000 was administered last week, so we can get that for you, Steve. They'll continue on this week and the week after that, and the grant application process is ongoing as well. So it's by no means that we stay at the 20,000 doses. We're happy and eager to allocate more doses to these kinds of clinics, so they should continue on. But sort of get a broader report on how much of the initial 20,000 allocation has already been administered. It's only been 1 week, and they're scheduled throughout July. I should note too that it's not just the community host clinics that are geared towards dose one. Of course, it is our pharmacy and physician partners do a lot of that kind of support, and we're hoping with walk-ins now essentially available throughout the province, and our big walk-in day where it's all walk-ins on Wednesday, that a lot of first dosers, if you will, show up.
Thanks. I have no more questions.
From CTV Winnipeg, Michelle.
So just to keep on that note about the Vaxathon, as the Premier called it, how will it work? Will people get to choose a vaccine type, or are we saving the Pfizer for the 12 to 17-year-olds?
So we're going to prioritize the Pfizer that we have for youth, because it is at this time the only product that youth can use, and there's a perfectly acceptable alternative for adults. So for the walkathon, as much as feasible, youth, the 8,000 or so Pfizer for the Vaxathon, will be prioritized for youth. And then in terms of how the day will work overall, it'll be like the walk-in process at the moment, except that it'll be all walk-ins. So when individuals show up, there'll be some sort of process, either a dedicated line or people being pulled out of a line if they're first dose individuals, to make sure that we get them covered. But certainly it's open to second dose individuals first who haven't made an appointment yet, or they just want to get it earlier. It's a province-wide team effort to bump up our stats.
Thank you. I wanted to ask you, Dr. Reimer, we're hearing some reports out of Israel that the Pfizer protection may not be as high. What do people do with that information when they read stories like that? And maybe just put it into a little bit of context as to what kind of report that is.
So I think you're referring to the report on Pfizer protection against the Delta variant specifically. And so there was one Israel study that did show lower effectiveness against the Delta variant, even after 2 doses. But we've also seen reports out of the US, the UK, and Canada that showed very high effectiveness against the Delta variant. All of those being, 80 and above. The one that I'm thinking of off the top of my head still saw 88% prevention of symptomatic illness with the Delta variant. So I guess my message for Manitobans would be to be cautious in the interpretation of one report from one country when we have more data. Sometimes one report is all we have, and in a pandemic we have to make decisions based on the information available to us. And so thankfully this time we have many different studies that have looked at this, and most of them have been very encouraging. And even in Israel, where they saw lower protection against symptomatic illness, they still saw extremely high protection against hospitalization. So, even in the one study that stood out as showing Pfizer might be less protective, it still was effective at the most important aspect, and that's severe disease. All of the public health measures and all of the changes you've seen around the world are not to prevent people from having a cold-like illness. They're really to prevent people from ending up in the hospital, preventing all of the deaths that we've seen. And so the Israel study continued to show that Pfizer was extremely effective, around 90% at preventing people from ending up in the hospital related to COVID. So overall, we've actually been very reassured that while there are many things about the Delta variant that make us more concerned, protection from the vaccine is not one of those concerns at this point.
Thank you. Just back to the supply and demand piece for Johanu. Has the province started to plan like what we would do with doses that we might not be able to administer in time, or would we just kind of lower our request to the federal government? What would happen there?
Yeah, so expiry for these doses is not currently a concern. Most of them are end of the year or even beyond that. So it's not so much an issue of expiry. But certainly we're planning on what happens when we reach a vaccine saturation point where there's more vaccine available than we need to bring in. A couple factors will have to go into that. As Dr. Reimer mentioned, if down the line we need more vaccine because individuals below 12 are now eligible, and to some degree demand. So we're watching very closely to ensure that we can bring in all the vaccine to ensure that we can vaccinate all Manitobans with 2 doses. But the speed at which we bring this in may depend on how fast we're able to go, which is it's really up to Manitobans to a large degree. We have our role still to play in terms of making sure that the vaccine delivery remains as accessible as possible, and hence why we're doing all the work with community hosted clinics. So we certainly have a responsibility in that regard, but the speed really is up to Manitobans rolling up their sleeves. For instance, that the external dashboard, the public-facing dashboard, has it's got a little box that says doses planned for the day, and up till about this week, that's always really reflected supply because demand was so high. So whatever we got in, we were able to push out. We saw until recently 20,000 doses plus planned for each day. The moment the supply exceeds the demand, what that really reflects is now how many Manitobans are willing to take a dose that day. So if we go lower over the next couple of days or next week and we drop to 15,000 or 12,000 or below 10,000, that doesn't mean that that's all we have capacity for or that's all the supply. That just means that those are all the appointments in the system for that day. Manitobans can, of course, show up on any one of those days and really use the walk-in option. We might do more than is planned for that day. But that planned doses for every day is now reflecting how much Manitobans want the vaccine more than anything else.
From CHVN, Taylor.
Hi, good afternoon. I'm wondering what's happening with July 14th vaccine appointments. Were any made, and if so, what's happening with those with the walk-in?
Thank you for that. There were no appointments made, so we've been planning for this day for a while. So we held off making any appointments. We just planned the day as usual in terms of staff and doses and so on, but didn't open up any appointments so that we could have this Vaxathon. There are still some appointments that day for non-supersite channels. There might be a couple pop-ups that day. There might be appointments that our pharmacists or physician partners have made. So those are not affected. This is a Vaxathon, a walk-in at the supersites.
Thanks. And considering we are on track to reach high vaccine rates soon this summer, what's going to be happening with the supersites when we do reach those and vaccine appointments and demand slows down?
Yeah, so we're actively in the planning process for that, for what VITF 2.0 and 2.5 and 3.0 might look like, and how do we phase out some of these larger assets like the supersites. This all depends on the epidemiology and the clinical direction, of course, but over time, if there's a requirement for a booster or if a new eligibility group opens up, like below 12. Speed and this level of capacity may be less of a concern. So there's a couple models we're looking at, leveraging our distribution channel partners to a large degree, moving things back into the regular health system, so to speak, and then slowly phasing out some of these larger pieces that may not be needed down the line. So we're actively looking at that. There's a couple plans in draft. It's become one of the key pieces of the planning component of VITF. But I think Manitobans will only really start seeing the impacts of that mid-August onwards, maybe early August at the earliest, because while we're able to look into the future, we're really still in the middle of the fight. We got over half of Manitobans vaccinated, which is awesome. But there's a whole bunch of individuals who's had a first dose who haven't had their second dose yet. We have to get them through. And there's a whole bunch of individuals who hasn't had a first dose yet. So while we're planning ahead for that, our focus is still doses and arms.
Thanks. I don't have a follow-up.
From the Winnipeg Free Press, Danielle.
Hi, Dr. Reimer. You said the REI report was critical to getting approval to move forward with the neighborhood vaccination approach. Who did you need approval from to adopt that strategy? How long was the vaccine team advocating for that change, and was it difficult to gain that approval?
So all decisions that are made with government approvals. That's how we function all the time, and I'm thankful that we're part of a democracy where that's where the people get to choose who makes the final decisions. So the work was no different than any other approval that we went through in any decision. We came out here and when we had so little supply, had to make those incredibly challenging decisions about who was eligible, which was really exciting to get to announce every time a new group was eligible, but also heartbreaking to have to tell other people that we knew were also at higher risk that they weren't eligible yet. And so we really grounded ourselves on the data, on the science, and set all of those decisions on that information. So, the approvals initially were to get an age-based approach because there was excellent data both locally, nationally, and internationally showing that age was the highest predictor of severe outcomes, that there really wasn't any other group or any other risk factor that made a bigger impact than age. And then as we move forward and as we had more supply, and then critically, as you mentioned, as we had data, we could ground the next decisions on the data that we had and went through the same approval process as we did for every decision before that.
On a different subject, as more Manitobans are fully vaccinated, can you tell folks what they should look for when monitoring for COVID-19 symptoms? What symptoms should trigger a test and how they might be different from pre-vaccine times?
Broadly speaking, the symptoms of somebody who gets an infection after a vaccine are the same as if you weren't vaccinated. I mean, the biggest benefit of the vaccine is that most people don't get an infection after the vaccine. And then the second benefit is that people who do get an infection tend to have a milder symptom course. But the symptoms aren't particularly different. So with the same recommendations we've been using throughout the pandemic, you can go through the screening tool online, and if you're answering yes to the questions asked in that screening tool and it tells you to go for a test, then you should still go for a test. Even if it's right after the vaccine, don't assume that it's side effects of the vaccine. If you meet the criteria in that screening tool, then we encourage you to go for a test because it's possible that you were infected just before or just after getting the vaccine. With some of the new variants, some symptoms might change over time, but so far, no major shifts in the symptom presentation that is changing our public health advice.
And I guess I just would like to switch back to the topic of the hotspots and the immunization strategy there. There are still a number of those communities in Winnipeg that are quite far behind other areas when it comes to uptake, despite having that early access. What would you attribute that lag to?
Well, one of the big reasons that those communities were identified was because we knew that they were experiencing higher risks and higher barriers than other communities. And so eligibility was definitely the biggest barrier, because regardless of any other barriers, if you're not eligible for the vaccine, then you can't get it. And so it was critical that the eligibility be addressed for communities where we saw that higher risk first. But that doesn't address any of the other barriers that people may face, and that's where our work has continued. And our partnerships leading to the urban Indigenous clinics have been really important, and then now also many other community-based clinics. Many of our physicians and pharmacists have been doing outreach as well, but we need to do more, and we need to keep working on this. Because the accessibility is not the same across the province, is not the same across the city, and even within a neighborhood. Different people have different barriers to seeking healthcare, vaccine or otherwise. So, I think the barriers to care are the biggest issue, and so we're committed to continuing to expand everything that we can to make it easier for people to get those vaccines.
From Global News, Amy.
Hi, my question's for Dr. Reimer. Some families are considering not getting together with people who are not vaccinated, whether that be friends or other family members. Is this a smart decision in order to keep people safe?
This is going to be difficult decisions that people will have to make ongoing about how they want to take different risks. And so public health will be developing advice on how we recommend people make decisions based on vaccine status. I know that the Public Health Agency of Canada has already started to develop some advice that they have for people based on vaccine status. So you can expect that we'll have some messaging as well for people. But for today, following the advice that Dr. Rusin provides regularly would be the same advice that I would provide. And so I'll just, ask people to listen to what he has to say about protecting ourselves, about protecting our loved ones, and still keeping contacts as low as we can.
Okay, thank you. And what is the risk for unvaccinated people mingling with vaccinated people indoors and outdoors?
I mean, the risk is the same as what it's been throughout the pandemic. We know that the vaccines are incredibly effective, but not 100%. And so when someone's not vaccinated, anytime that they are having contacts with other people, they are putting themselves at risk of infection, which is why we've been in this unpleasant circumstance of having public health orders that mandated reductions in contacts. But even when the order doesn't mandate it, if you haven't been vaccinated, we still worry that people could be infected and that some of those people will get severely ill. So, going forward, the risk is no different. We want people to get vaccinated to provide that best possible protection. Because if you're not vaccinated, you don't have any ability to prevent that infection like you do after the vaccine and after that immune response. And so likewise for those people who are vaccinated but where it doesn't work, we don't know ahead of time which individuals will be fully protected and which individuals may not have responded with a strong immune response. And so we are still asking people to be cautious and to try to reduce those contacts, broadly speaking, to prevent illness and to help us get a lot lower numbers in our hospitals. And certainly we want to stop hearing about any deaths at all related to COVID as we go forward.
Okay, so based on these facts, and I know that you said there is going to be an announcement about this in the near future, but would you recommend that people try not to mingle with unvaccinated people, even if it divides some families or friends?
So I'm not providing specific recommendations on that. I think it's important that we make sure that public health has had the opportunity to to discuss broad recommendations, and that we look at the data, the local epidemiology, as well as the messaging from the Public Health Agency of Canada. So, you know, I look forward to hearing from Dr. Rusin and the rest of the public health team on the advice going forward. For today, you know, his message continues to be to focus on the fundamentals. And so, you know, we want to be consistent with that message that, you know, wherever possible, reducing your contacts is still beneficial. But we also are trying to move towards, you know, a post-pandemic world, not necessarily post-COVID, but post-pandemic. And so, you know, we will be shifting and creating new public health messaging and recommendations as we go forward, but I don't have any of those finalized to share today.
Okay, thank you.
From the Brandon Sun, Kimberly.
Good afternoon. My question is for Mr. Botha. I'm just wondering, apparently the QR code is specifically for the iPhone, not the Android. When is the Android version coming? What's being done in the meantime to accommodate those that don't have iPhones?
So thank you for the question. The role of the task force, for the most part, is really about getting the dose and getting it into the arm. And we've been supporting the immunization card by ensuring that there's an accessible way to apply for it using our call center, and ensuring that records are correct so that individuals can apply for the card. But in terms of the technology and how it's used and policies around it, those are bigger government questions that sort of transcend my operational logistical role of the task force. I know that the tech side in government that is working on this wants to make it you know, as effective and efficient as possible, certainly, and they'll probably look at different platforms, but it's a bigger question for government.
Also add on that, because I have an Android phone, that it does actually work with Android. So not my role in the task force, but having done it myself, the Android app, you can get it from Google Play, and it does work.
Okay, thanks for that. I appreciate it. So we're hearing that restaurants not all restaurants have access to reading the QR code. And I'm just wondering, are you aware if there is a cost involved in having access to the technology to read those QR codes? And if not, what can say the restaurants do? Because people are going in with their QR codes, and some restaurants are unable to read them. They haven't applied for their cards. So I'm just wondering what you have to say for that.
So I'm not aware of the technical details there, but Dr. Reimer is clearly more savvy than I am on tech stuff, so I don't know if you have any input, Dr. Reimer.
I mean, it's a free app that you can get either from the Apple Store or from Google Play. But as far as what restaurants are doing, again, that's certainly not my role in the task force at all. Just sharing because I had the Android phone that I know that part works. But the app itself does not have any cost associated with it. So it would require a smartphone, but otherwise doesn't directly have any cost at that level.
Okay, thanks for that. My last question. So with all the problems that, with the phone lines, and we finally are able to access it, according to Mr. Botha today, and, this QR coding, I'm just wondering, why didn't the province take the steps to issue immunization cards automatically for everyone once they reach their second dose time frame?
Yeah, so again, the Vax card and the technology around it, how it's used, transcends the mandate of the task force to a large degree. But I think what I can say is this is an immunization campaign, the scope of which we've never seen before, and providing an identification based on data that essentially is aimed at data that should reflect the entire population if we can get everyone vaccinated who are eligible. That's a massive endeavor as well. As far as I know, the immunization card in the Manitoba context is one of the only of its kind in the country, and its authenticity and how it works and and its security is something that's actively being looked at by the jurisdictions. So it's new, it's innovative, and I think anything new and innovative, you learn as you go. But I think that's as much as I can say about the card.
Our final reporter this afternoon from CJOB, Skylar.
Hi, guys. Thanks for your time. Just sticking with the vaccination cards. Obviously, there is a process in place for folks who don't have record of their first shot showing up, to kind of rectify that and end up getting their card. But we've heard from some people where that just isn't working for them, and essentially the first shot never happened in the eyes of the province. One texter to our station says they're actually going for a third shot later this week or maybe next week just to get 2 shots on their card, and they're going to be able to get it. Is there any way that the province can fix this for everybody?
So I can't speak to that particular example. I know that the oldest records that the team is working through is about a week old, and again, those are the ones that are more complicated to work through. For whatever reason, if it's out of province, if it needs to be validated, if the dose was administered by a pharmacy or by a physician or maybe in a remote location where we have to double check when and where it was, those can take longer. Many are resolved in 3 days. There's a process in place to assess whether the dose occurred, so that we don't have to have individuals go get an extra dose for this. It's again, the records that have to be corrected are the vast minority of them, and we're actively working through them every single day. It's less than 1% now. But with the amount of data that's being entered every single day, and the amount of out-of-province individuals coming in, this is bound to happen, and hence why this is built into our process now. It's not just a one-time thing. Whether it's the online web forms or whether it's the phone call now, we have that option for everyone to have their data corrected if there was some sort of error. And we've worked through thousands already, so it's working, and we're trying to make it as fast as possible.
Okay, thanks for that. While I've got you, Johanu, I guess following up on Bart's question from like an hour ago, the first and second dose projections for roughly mid-August are there, and we saw them in the slides today. But I also noticed this last week too. They, after maybe, I guess, the end of July, the beginning of August, they basically go up at the exact same time. And that just from a purely mathematical standpoint, that doesn't make a whole lot of sense to me, given there's a 4-week waiting period between the 2 shots. Is there any answer you could provide me, with that?
I think what that I'll have to look at the graph and get the specific question, but I think what it reflects when the 2 lines converge, that's not that the same individual is getting their first and their second dose at the same time. What it reflects is that at this point, almost every person who has that first shot is getting their second shot. So that rate or the ratio between the two are lining up. It doesn't reflect the same person. So the interval still exists. It's a bit technical, so maybe this is a tech briefing type question I should answer.
Yeah, it would help with the graph, but that answer makes a fair bit of sense, so thank you very much. And then, Dr. Reimer, I guess just to finish up with you, BC and I believe one other province are allowing all 2009-born residents to get their shot. This seems like an easy way to bump up the number of eligible Manitobans by, I guess, a few thousand. Is Manitoba considering doing that so someone that's, say, 11, but their birthday is coming up in a couple months is able to get the shot?
So Health Canada approved Pfizer for people based on their age at the time of the shot. So the approval is 12 plus, and Manitoba, like most provinces, decided to stick with age 12 instead of looking at birth year. But each province has different logistics that they need to work through when it comes to the rollout, the planning, the booking. So I can't speak to, I think it's BC and Alberta that have used birth year rather than age at time of vaccine as to why they went that direction. But what I can say in Manitoba is that the logistics worked out well with following Health Canada's approach, which is that people who are 12 and over are approved for use of Pfizer, and we plan to stick with that until they change their approval.
Thank you.
Thanks, everyone. This concludes our media briefing.